And it is my pleasure to introduce you to our next speaker, Dr. Sonja Rasmussen, professor in the Department of Genetic Medicine at Johns Hopkins School of Medicine.
So it's my pleasure to talk to you today about the use of case reports and case series in understanding whether a medication is a teratogen. And first, I'm just going to, then I'm going to focus on isotretinoin teratogenicity. So what are case reports and case series? I think most of you know case reports are clinical descriptions of children born with birth defects or other adverse outcomes born to mothers who have a particular exposure during pregnancy. And case series are just collections of those anecdotal reports. But I think it's important to note, I mean, it sounds kind of random, but those case reports and case series have played really an important role in the identification of previous teratogens, and a couple of previous speakers have alluded to that. I'm just going to give you some examples. When you think about rubella, we know rubella is a teratogen that was identified in 1941 by an ophthalmologist that was seeing kids with a particular kind of cataract, and then recognized that rubella was a teratogen. Thalidomide, you saw the pictures in some of the earlier talks too. This is a very particular kind of limb reduction defect. I've worked in birth defects for many, many years. I've never seen a child with this particular kind of limb reduction defect. So that really was a red flag to physicians in Germany and in Australia that something was going on. Then they asked questions to those patients and realized that they were taking thalidomide, and that's how thalidomide was recognized as a teratogen. Fetal alcohol syndrome, the reason we know about alcohol being a teratogen is because of dysmorphologists Ken Jones and David Smith, who recognized the particular features that you see in kids with fetal alcohol syndrome. And then finally, with Zika, when we started hearing about a lot of kids with microcephaly in Brazil, when I was at CDC, and we started hearing about these kids and then started seeing pictures. It wasn't just plain old microcephaly. You can see how these kids really had a very unusual shape to their head. It wasn't just a smaller head, it had an unusual shape. And they also had rugations on the top of their scalp because their scalp was really growing for what was originally going to be a bigger head. And then the brain kind of collapsed when the virus was damaging it. That was a very particular phenotype that had only been seen about 20 times in the literature before then. That really helped us to make the case that Zika was a teratogen. So now I'm going to talk about, I have to switch on the right one. Now I'm going to talk about isotretinoin. So oral isotretinoin, or you may know it as Accutane, was first introduced in the United States in September of 1982 for treatment of severe recalcitrant acne. And I have to say, from the very start, based on animal studies, the drug was pregnancy category X. It was meaning that there was no indication for use during pregnancy, but of course, a lot of people got pregnant on it. This is what the package insert said. Patients who are pregnant or intend to become pregnant while undergoing treatment should not receive Accutane. And should pregnancy occur during treatment, the physician and patient should discuss the desirability of continuing the pregnancy. Obviously, different political times. So where do we start seeing isotretinoin case reports? Well, the first one that was in the literature was from Franz Rosa from the FDA. It was published in the Lancet as a letter. And he reported that there were between September of 82 and August of 83, there were 12 cases of adverse pregnancy outcomes associated with isotretinoin that had been submitted to the FDA from the manufacturer. 5 were birth defects, 2 with hydrocephalus, 2 with hydrocephalus with a heart defect and small ears, and 1 with just small ears, microtia, and then 7 spontaneous abortions. And that led to a letter from the manufacturer to physicians and pharmacists asking for more information. The next one that was published in the MMWR, which is near and dear to my heart. I used to be editor-in-chief of MMWR, and there were 29 case reports. Again, this was reports to the FDA. And you can see CDC came right out there. This is kind of brave from my experience at CDC, but the title was Isotretinoin, a newly recognized human teratogen. There were 29 case reports, some prospectively identified. So you knew the mom was pregnant, you followed her, she had isotretinoin, and then you saw the birth defects versus babies born with a birth defect and somebody asks the mom and says, oh, you took isotretinoin. So obviously prospective data are better. And from this, although the total number of exposed pregnant women is unknown, they didn't know that denominator, the consistency of the laboratory and human experiences with isotretinoin exposure during pregnancy provides sufficient evidence to conclude the drug is a human tratogen. This is next one. This is just a single case. It was actually put together by Paul Fernhoff, who was at Emory, and Ed Lammer, who was at CDC, single case, but had features that were really fairly typical, similar to what had been seen in those animal studies. So they saw kids with a small chin, with a particular kind of heart defect, hydrocephalus again, and then those small and malformed ears. And they said, this is similar to what was seen in those pigtail monkeys exposed during gestation to retinoic acid. And then this one here, another bioneurologist, Ira Lott from California, another single case, but very consistent with the other cases. Kids that had those very abnormal small ears and unusual faces, severe developmental delay, and a particular kind of hydrocephalus called aqueductal stenosis. And then here is the paper that would really kind of, I think, put the nail in the coffin by Ed Lammer. He was at CDC at the time. There were 154 pregnancies, of which 95 ended in elective abortions, 26 without major malformations, 21 malformed infants, and then 12 spontaneous abortions. Of those, only 36 were really looked at prospectively, the better way of looking at them. And when they looked at that, there were 5 malformed infants out of the 28 pregnancies that were completed, or about 18%. When they did a relative risk, looking at the very particular kind of defects, and then looking at the rate of those in the Metropolitan Atlanta Congenital Defects Program, they got a relative risk of 25. Then they looked at, is there this characteristic pattern of malformation? Because they knew from thalidomide and rubella and other things like that, that you would expect a characteristic pattern. And that is what they saw. Craniofacial, the ears, the face, heart defects, defects of the thymus, and the defects of the brain with the hydrocephalus. So they, Ed and his colleagues concluded a pattern closely resembles that in animal studies, and isotretinoin teratogenicity is a deleterious effect on cephalic neural crest cell activity. So that's embryologically what they hypothesized was going on. So can we just use those case reports and case series to assess causality? And I think it's important to note that you can't just see a single case and say, oh, now that means that drug caused this. Obviously, that isn't what you can do. But you do have to go through some sort of approach. And this is what we did with Zika. We did use Bradford Hill criteria. I'm not going to talk about that today because I assume that most of you are more familiar with Bradford Hill criteria, but I'm going to talk about Shepard's criteria that's specific to teratogenicity. This was put together, these were put together by Tom Shepard. He was one of the pioneers of teratology. And he wrote a paper, a letter to the editor on proof of human teratogenicity. It's interesting, this is the table, and what he did is he reviewed what we knew about teratogens and what evidence had been used to show that medications or other exposures were teratogens. And he put together this list of 7 things you should consider, but really only 1, 2, 3, and 4 were important. 5, 6, and 7 were kind of gravy. So I'm just going to go through the 1, 2, 3, and 4. He also noted that you can either need number 1, 2, and 3, or 1, 3, and 4. You don't need all 1, 2, 3, 4. So he said, well, you can do it by epidemiologic evidence, but he set the bar, I think, pretty high for these epidemiologic studies. You can see control for confounders, sufficient numbers, exclusion of positive, negative bias factors, prospective studies of possible and a relative risk of 6 or more. You also have to have a proven exposure to an agent at a critical time, and you have to have careful delineation of the clinical cases. And he notes that a specific defect or syndrome, if present, is helpful. Then he talked about what we've talked about already, that a lot of teratogens have been identified because they cause a characteristic pattern of malformations. And this has been called rare exposure, rare defect. So again, got to have the proven exposure during that critical time, got to have a careful delineation of the clinical cases, and once again, a specific defect or syndrome, And then it's got to be a rare environmental exposure associated with that rare defect. So probably, he said, 3 or more cases. And this is what we use. This is the pattern that we used, or the approach that we used to make the case that that Zika was a cause of birth defects in the New England Journal in 2016. So we were able, the epidemiologic data weren't there then, but we had proven exposure at a critical time. We had very careful delineation of clinical cases from some of the pediatricians in Brazil. And then we had rare environmental exposures associated with a very rare defect. Only 20 times in the literature had this very specific type, this fetal brain disruption sequence been published before. And here we were seeing hundreds of kids out of Brazil with these findings, and also seeing a lot of kids being born in other countries with moms that had had very brief exposures through travel. So what's happened? So we've talked about isotretinoin, and I was asked to talk a little bit more about that. And what have been the efforts? How do you, once you know something is a teratogen, how do you keep women from being exposed to it? So with isotretinoin and with other teratogens, the goal is to ensure that if somebody's pregnant, they don't start on that medication. And if someone's taking it, they don't get pregnant. Of course, we know that 50% of pregnancies are unplanned. So that's going to be a challenge, right? And these are some of the programs that have been used to try to reduce the risk to pregnancies with isotretinoin. So you can see 82 to 87, a warning on the insert, and a patient brochure, then pregnancy prevention program, then the SMART program, and then the iPledge program. I'll show you a little bit more about these, but in 15 minutes, I can't go into a lot of details, but you can see they've really started with just a warning on a label, then revising the warning, then adding more and more and more to the current iPledge program, where you need to have 2 pregnancy tests before initiation, and then a monthly pregnancy test. Registration in the database by patients, prescribers, pharmacists, and wholesalers. You have patients need to answer questions to show that they recognize that this can cause birth defects, and then monthly identification of 2 contraceptive methods by patients and doctors. So how has that gone? Well, you can see here, this is a paper that was published in JAMA Dermatology from FDA reports of pregnancies that were exposed, were associated with isotretinoin. You can see, I'm not sure, I was worried that I'm going to push the wrong button here, but if you, you can see the peak there is when the iPledge program was put in place. So you can see that the iPledge program has had a good outcome in the drop in number of pregnancies that are occurring. But still somewhere between 200 and 300 pregnancies a year are occurring, even with the iPledge program in place. And I want to emphasize how challenging this is. And this is, iPledge actually was put in place before FDA, the FDA, the Food and Drug Administration Amendments Act of 2007 gave FDA authority to require drug sponsors to develop these REMS. But these risk evaluation and mitigation strategy programs are really tough. You want to be sure that people we don't have exposed pregnancies, but we also, if there's people that need that drug, then you want to be sure they can get them. So it's really walking this fine line, trying to be sure. And I respect my colleagues at the FDA greatly, because I think this is really challenging. So it's a strategy for managing drug-associated risks, going beyond professional labeling. And as you heard from Sonja earlier, the other Sonja, they can include medication guides, patient package inserts, communication plans, and then elements to assure safe use, such as pregnancy tests. So I just want to say I was honored to participate in a FDA meeting earlier this year to talk about how to update iPledge. And there are some updates that were put in place from what I see from the website in November 30th, 2023. It really made me realize how challenging this must be to be at the FDA and to try to find that fine line. The dermatologists that were saying it's so hard to get our kids, our patients on this medication when they need it, and not have them lose access, but also to prevent pregnancies. So I'm going to end by, we often don't have the evidence that we need. That's what we keep hearing again and again. We don't have the evidence that we need to make decisions about safety of medications. But case reports and case series can play an important role. Really, lots of times in generating hypotheses, but sometimes even going further in that. And some of that is that we don't want to wait for that perfect study. We can't wait for that perfect study. We need to stop people from taking it if it's something that could be causing babies to have serious outcomes, adverse outcomes. So the rare exposure, rare outcomes, a characteristic pattern of malformation has been used to identify teratogenic exposures in the past. And then just ending by saying developing these REMS programs to avoid teratogenicity is very challenging.